I'm on my immediate right-hand side, and in the middle is Dr. Motsoaledi, the Minister of Health, followed by Dr. Joe Parker, the Deputy Minister of Health, followed by the MEC for Health from the province of Northwest, Bugonibu Prima. We also have the MEC of Health from the MEC of Health from the province of Northwest is MEC Lehari. We've got the MEC from the province of the Eastern Cape, the MEC Kapa. We've got the MEC from the province of Limpopo, MEC Mashego. We've got the MEC from the province of Mpumalanga, MEC Manzini. We've got the MEC from the Woods province, Ms. Gomora Lhoko. We've got also joined by the MEC from the province with two surnames, Honorable Ms. Melani. We've got the Honorable MEC Wagner from the province of the Western Cape. We've got the MEC from the province of Free State, the MEC of Matlati. Yeah, just wanted to get the name correctly. We've got also the MEC from the province of Northern Cape, which is the largest province in the country, the MEC Mukwele. So without wasting, and also I've got the Director General of the National Health Department, Dr. Sandile Muthelezi. So on that note, I'm not going to waste any time. We've also got the senior officials from National Department of Health, senior officials from all 9 provinces. So without wasting time, I'm going to hand over to the Honorable Minister of Health, Dr. Motsoaledi, to take a lead. But when it comes to the questions, because this is a collective session, all the MECs will participate. Over to you, Minister.
Do I have a mic here, or am I using this? Thank you very much, Program Director, my colleague, the Deputy Minister of Health, Dr. Joe Parker, my colleagues, the MECs of Health from all our 9 provinces, as introduced. Ladies and gentlemen from the media, good afternoon and welcome to this media briefing. I just want to add that while the Program Director said this gathering, which we call a National Health Council in Health, is called a MINMEC in other departments, does not only differ in name, it also differ in character, stature, and status, because in the other departments, MINMECs are for coordinating purposes, to help ministers of those departments to coordinate with their MECs. But the National Health Council is a statutory body with decision-making powers, because unlike the other MINMECs, it consists of all 3 spheres of government: national, provincial, local government, as in SALGA, and the Surgeon General of South African Military Health Services. So that's why it's a statutory body. Thank you for making time to join us today. And the purpose of this media briefing is to provide update on a number of health issues which have dominated the public discourse over the past few weeks and months. We'll start with employment of healthcare professionals. Early this year, the country woke up to widespread dissatisfaction about the employment of healthcare professionals, especially doctors, in the midst of shortage in the public healthcare system. Unfortunately, at that moment, the Department of Health could not do anything due to budgetary constraints, which were brought about by consistent austerity measures practiced by the country for over a decade. However, the new budget, Foster, lots of people who are sending you messages here, man, and they are blogging. Is there any way you can stop it? They are sending you messages, emails, city press, what? Is there any chance that I can speak in peace? Because they block everything I'm reading. Yes. No, they are sending him things instead of coming here.
Disconnect.
Yes.
Disconnect.
No. Okay.
No, it's still on.
It's not connected. Here it is. Uzbalo is GCIS now.
Disconnect.
I'm trying to disconnect. Disconnect.
No disconnect. Oh gosh.
Oh, it's on.
1 second.
Okay. I was going to say, however, a new budget presented by the Minister of Finance on the 12th of March 2025, we believe we are in a position to announce to you today that the Council has approved advertisement of 1,200 jobs for doctors, 200 nurses, and 250 other healthcare professionals at the cost of 1.78 billion rand. The Human Resources Unit will soon commence with recruitment processes once all logistics have been finalized. We now come to the second most topical issue in the public discourse. The procurement of hospital beds, linen and mattresses. One of the most embarrassing experiences the public health sector had to endure is the shortage of simple things that will make the stay of patients a worthwhile experience. In fact, one of the biggest differences between the public and private sectors are the hoteling services characterized by the issues we have just mentioned, not much of clinical differences. As an example, we wish to quote to you that in the widely reported problems of Helen Joseph Hospital, 7 complaints were reported by the complainant to the Health Ombudsman, Professor Taule Mukwena. 5 of the complaints were dismissed as unfounded, and they've got to do with clinical care. In other words, the Ombudsman said clearly there's no substance in the claim that clinical care was substandard. But the other 2 complaints, which have to do with these hoteling services, were upheld by the Ombudsman and widely reported in the media as if they were the only complaints. The other 5 were completely forgotten. It is for that reason that we need to correct such things. And today, we wish to announce that we have checked with all our province by province, what the needs are in the form of beds, bassinets for babies, for newborn babies, and all the other issues that are needed. We'll remember with a sense of shame how babies were put in cardboard boxes in Mahikeng Hospital in the Northwest Province some few years, very few years ago. Today, we are here announcing that the Council has decided that 1.4 million articles need to be bought and delivered to our hospitals. The 1.4 million articles will consist of 25,000 beds, which are ICU beds, general ward beds, 3-section electric beds, 4-section electric beds, multifunction electric beds, etc. and there will be 25,000 of them. They will cost 725 million rand. Secondly, we will have to buy mattresses for these beds. It looks like a very simple thing, but in some provinces, there have been negative experience about it. That will be hospital bed mattresses, pressure mattresses for people with strokes to avoid bed sores, infant cot mattresses. We will buy 80,000 of them to the tune of 38.7 million. We will also buy bassinets, which are beds for newborns. They are not necessarily cots. These are for newborn babies to avoid the cardboard box embarrassment, which I've mentioned. We'll buy 76,525 of them to the tune of 309.5 million. We will also buy linen, including bed sheets, pillows, and all the other things that are necessary to make patients feel comfortable. We'll buy 1,250,000 of them to the tune of 273 million. The total cost for this procurement of 1.4 million articles will be 1,346 million. That will be the total cost. The other thing we want to report to you, which was widely reported in the media, is the issue of oxygen plants. It is common cause that during COVID-19 period, many health facilities used to run out of medical oxygen, which was one of the mainstays of treatment, by the way. The Global Fund then offered to put up self-generating oxygen plants called pressure swing absorption plants, or PSA units. The Department of Health gave this work to the IDT as an implementing agent, which were to implement in 55 of selected hospitals across the country. Unfortunately, persistent media reports about possible corruption and electoralities in the procurement process continued. Even up to a few days ago, there were still such media reports. The Minister of Public Works and Infrastructure, as the authority to whom the Department of Public Works is reporting, entered the fray and announced that it's going to conduct investigations. Well, some people were fired in IDT for these purposes. As a Department of Health, we support the investigations. We have even asked the President to enter the fray also at his level. And he has agreed. I'm sure you'll announce very soon. But we support the investigation. But we are worried what will happen to the Department of Health while these investigations are going on. After all, this is donor money. And the donors may just get angry and say it's not safe to donate in South Africa because of these allegations of corruption. We were worried about that. We then decided as a Department of Health to remove the project from IDT and send it to the Independent Development Trust under Public Works and send it to the DBSA, the Development Bank of South Africa, and which reports to the Minister of Finance. And we have agreed with the Minister of Finance to do that. We've met the two senior executives in the Development Bank, and they've agreed. But we used to inform the public that at the time these newspaper statements came out, no project had started. There's a belief that some money has been used already. Nobody got the money, especially those who are alleged to have got the tenders in a corrupt way. They never got any money. So it was very easy because of that to move the project to the DPSA, the Development Bank of South Africa, and we wish to report that those projects will continue under the tutelage of the Development Bank of Southern Africa, and we are happy with that state of affairs. Whatever outcomes from the investigation, whatever it is, it will find us already progressing so that our hospitals can manufacture and produce their own oxygen. The last issue I want to share with you is the review of human resource policies in the health sector. There are a lot of health policies adopted at the dawn of democracy, which we believe are now either obsolete or no longer serve the purposes for which they were intended. Some of them have created unnecessary costs without any tangible benefits. We can even say some have actually contributed to the undermining of the public sector's ability to deliver quality services. In the National Health Council meeting held on the 28th and 29th of November 2024, this matter was discussed very thoroughly. A decision was then taken that these policies need to be reviewed. As the Minister of Health, I appointed a review committee in terms of Section 91, subsection 1 of the National Health Act of 2003, Act number 61 of 2003, read with Section 91, subsection 2 of the same Act. I appointed a team of people who will do this review work. And the team consists of Dr. Cassius Lubisi, the former Director General in the presidency. I believe is the longest serving Director General in the presidency throughout this period of democracy. There is Ms. Bongile Mkunu, who is the former registrar of the South African Nursing Council. She is now serving as a board member of the Health Office of Health Standard Compliance. We've got Professor Letitia Rispel, Professor of Public Health Sciences at the University of Pretoria. We've got Professor Eric Buch. He's the former Dean of the Health Sciences of the University of Pretoria, the immediate outgone chairperson of the National Health Laboratory Health Services. We've got Dr. Carter. He's a former Deputy Director General of the National Department of Health. Before that, he served as the CEO of Grooteskier Hospital in the Western Cape and Tygerberg Hospital also in the Western Cape. He was a CEO of both hospitals before joining the National Department. We also have Dr. Rajan Mora. He's the CEO of Nelson Mandela University Medical School. We also have Professor Bini Luke, a physician and member of the Medical and Dental Board of the Health Professions Council of South Africa. We have got Ms. Nomvula Magawa, Strategy and Policy Specialist. And we have got Professor Busisiwe Ngama. He's the Deputy Vice Chancellor for Health Sciences at the University of KwaZulu-Natal. And last but not least, Professor Somadoda Fikeni, who is the chair of the Public Service Commission. The team or this appointment and the review will be gazetted in the government gazette today or tomorrow. We just thought immediately after this announcement we'll gazette and they'll start their work. We are really hoping that the team will do this work in a period of 6 months and report to us. We are painfully aware that we once said so in 2014 when the health market inquiry was appointed. We said they'll finish in 6 months. It ended up being 5 years. But we all know the reasons. We are hoping this won't happen to this committee. Ladies and gentlemen, that's all we had for you for today. Thank you very much.
Thank you to you, Honorable Minister.
Oh, yeah, the DG is reminding me which policies are they going to review. First and foremost, we want them to review the RWAPS policy. RWAPS means remunerative work outside the public service. We want the policy to be reviewed because we believe it's one of those which we can term obsolete. For the reason that immediately after the era of democracy started, the trade unions, led by COSATU, approached the state and complained that public servants are not paid enough by the state, unlike in the private sector. And so the state must allow public servants to do remunerative work outside the public service. That's why it was named like that and called RWAPs, remunerative work outside the public service. Of course, the government agreed because it was true. I still remember during that era when we started interviewing people for government posts, I used to see a lot of professors applying for chief director's posts, which I thought are at the lower level than what professorship holds. But I was told that no, it's much more profitable, or to be a chief director in government than a professor at the university. But those things have changed dramatically, especially in health more than in any other. When OSD was implemented, it's the opposite now. There's no professor or any senior specialist in health who will ever agree to take a management position in the department because OSD is paying them much more. So the claim that they were being paid little is no more there. And so we don't see why the RWAP policy cannot be reviewed. Why in health, RWAPs in its original form was for all public servants. But for some reasons, which might be obvious to other people, but not to some people, but not to others, it took root in health. Whenever you say RWAPs, people think of health. But RWAPs was given for anybody. I've never heard people in the Department of Education doing RWAPs or in whichever other department. The police, I've never heard the policemen on RWAPs or the army or social workers in social development. The whole RWAPs thing, which was passed for everybody, is in health only, and we believe it must be reviewed. The second policy which you want reviewed is committed overtime, which over the past few days have been making rounds. The issue of committed overtime, which I believe came into effect because it was believed that every doctor needs to be on call at one stage or the other. That committed overtime is being abused, but it's also not being managed very, very well, together with RWAPs. And people might argue then that is because you are poor management or the poor management of the departments of health in various provinces, that RWAPs and the committed overtime are not managed well. I just want to remind you, I've just said here, that there's no senior person, especially in medicine, who will agree to take a management position in the department. So the management positions are taken over by junior people. And the people who go to do RWAPs are very senior to them. And so it's very difficult to confront your senior. And that's the problem that we're faced with. You can check in all our hospitals. Whenever we advertise a job for a CEO of hospital, all the senior doctors are not interested at all because of what OSD pays them. But once the junior person agree and take the job, they look at them as junior and they undermine them profusely. And the junior people also cannot confront. You can't confront somebody who is much, much more senior than you and holding a higher status. And for this reason, we believe that's why we're experiencing problem. The third that will be reviewed is the issue of community service. Community service was introduced years back, specifically because doctors were refusing to go to rural areas. They had a wide choice. And as you know, those choices, they are still fighting for them. For instance, when we place interns, I'm sure the media knows it, because people rush to the media to complain. When we place interns, every doctor who have just qualified for internship, they will choose Cape Town in the Western Cape. They will choose Pretoria and Johannesburg in Gauteng, or maybe even some cities in Ekurhuleni. They will choose Durban in KZN, and they will choose Bloemfontein in the Free State. If we are lucky, they will choose Kimberley in Northern Cape. MEC, forgive me, but that's true. If we are lucky, we even, yes, or if we are very lucky, they will choose Polokwane, Limpopo. But by and large, Nelspruit, if we are lucky. Okay, yes. But colleagues, jokes aside, there are doctors who are known to have waited for 6 months without a job, refusing internship in rural areas, and wait without a salary. That used to happen, and people might not be aware of it. Now today, every doctor will run for any job that is available. There's no question about it. So why should we relook at this issue of community services? Because it was done to make sure that even rural hospital do get a doctor at least for a year, at least. Now that is no longer important because doctors will go. We want to review it. The last policy which we want to review, which I heard talking about under correction from the Department of Basic Education, that they've already dealt with this issue, is something called rural allowance, where people were paid extra because they are working in rural areas where there's no tar road, where there's no electricity and they can't watch TV, where there's no clean running water. That situation over the past 30 years have actually changed. I know when I was the MEC of Education in Limpopo, we used to complain about it. Somebody staying right in the center of Polokwane, but working about 30 to 40 kilometers outside Polokwane, which is regarded as rural, earning a rural allowance, but enjoying the stay in a city. Because Polokwane is a city now. It was a small town during that time. So all those things we want to review it, and people will be consulted. This team who is allowed to co-opt, especially people with skills, especially from the legal profession, they can co-opt. We encourage them to interact with the deans of our medical schools who are responsible especially for our teaching hospitals, but they must do their work, and we pray that in 6 months they'll have finished the review. We encourage members of the public to interact with them so that when they give a final report, nobody should claim that they were not consulted. Thank you very much.
Thank you very much, Honorable Minister. Members of the media, as I indicated that the Minister is speaking on behalf of collective, so they're going to share their questions among themselves. We've got the roving mic. Where is it? The mic? Okay. Yeah. We can now pose questions to the leadership here. Let's hear. The first question is ENCA. Next. You introduce your name and the media house you come from. So it'll be number 2, number 3, Newsroom Africa. Another hand. For now, let's take these 3 hands. We'll take the second round. Over to you. Hi.
It's Heidi Jokos from ENCA. Minister, I've asked you this many times, but I'm going to ask you again. Perhaps there could be a clearer answer now that you have all your MECs here from all provinces. But the Finance Minister, during his budget speech, said that provinces have to find money to fill the gap for the funding that is being cut off by the US.
They have to what?
Find the money that has been cut off by the US. So I would like to know if that was at all discussed and how you are going to deal with that. Thank you.
Heidi, are you sure? None of us remember ever
he said that.
so.
Yes, we even have the
that provinces must find money.
Yes, so what he said was that the national doesn't have the money to give help. So provinces within their budgets have to find money to fund these programs if they've been affected by the funding that is being cut off by the US?
Hey, I'm not aware. Maybe I missed it. Yes. Maybe let me answer it before you go to the others because it's very important. I'm not aware of that, but I will really be surprised where we think provinces will get the money from. Because nobody, including national itself, we've had a series of at least 3 meetings with Treasury to look at what can be done. We had a series of meetings with international donors, even local ones. All of them have said they'll look into this issue, but all of them made it very clear-headed that they do not have the capacity to replace what America was giving in research and everywhere else, HIV and AIDS. The only thing that we guaranteed and provinces are doing is that nobody who is on ARVs must stop having their ARVs because they are not there. And secondly, that nobody who needs to have ARVs must be told that they can't be provided because of these budget cuts. That's why on the 25th of February, we launched a project to look for 1.1 million more people in addition to put them on ARVs because we were very sure, because we are buying 90% of our ARVs and 10% from Global Fund. Again, on the 24th of March, World TB Day, we announced that we look for 5 million people every year who must be screened for TB and those who are found to be positive to be treated, because we are quite sure that we won't suffer any problems in that regard. Now I can announce to you today that 2 weeks ago, the Global Fund established more or less at the same time as PEPFAR, the Global Fund to fund the HIV and AIDS, TB and malaria, has given us a permission to order 1 billion rand worth of ARVs. And the DG has already put in that order, 1 billion rand worth of ARVs, which will be put for by Global Fund. I can say without any equivocation that ever since this announcement by the US, this is the first tranche of help that we ever got, the 1 billion rand worth of ARVs. Before that, we have got many promising funds. I don't want to mention him here because promising remains the word promise, and it remains promise, and we haven't got anything. I wouldn't like to put people under pressure to mention them here, but I don't know how our provinces will even try to do anything other than the other. I mean, in terms of providing money, the other thing we have said they must do, which they are doing, is to try and make sure that people who were receiving their treatment elsewhere in clinics that were closed must be taken over and absorbed by our clinics and hospitals.